engaging session. So thank you so much once again. We just want to get started. I think we have a good quorum. And just to get started, our webinar today is about success in measuring program outcomes. And the reason why we are focusing on this theme is because the Global HIV Prevention Coalition is working towards accelerating progress on HIV prevention, and the prevention roadmap does chart a way for country level actions to be able to achieve these ambitious HIV prevention targets. Strategic information is critical for the design, monitoring, and evaluation of condom interventions, and measuring the right indicators to provide feedback on the outcome and impact on condom use is important to tracking progress on prevention. And so for today, we want to hear from 2 countries that are making good progress in monitoring their programs to the last mile and how that is informing their program design. We also have some 2 exciting presentations from 2 organizations that are delivering health products and services to the last mile, and they'll be able to share with us how they have innovated in using that strategic information to inform program design. For the 2 countries, we'll also be able to hear from UNFPA, who will be sharing with us. Rosemary Kindyomunda from UNFPA will be sharing with us about the Condom Strategic Initiative. Then we have from Uganda, Boniface Epoku, who will also be sharing with us about how Uganda has succeeded in measuring the right indicators for a successful condom program. We'll have Ghana, Dr. Koduah Owusu, who is the head of the clinical care of the National AIDS and STI Control Program, who will be sharing on using data to design, manage, and monitor quality condom programs. We then have Triggerise, Dr. Hildah Essendi, who is the Director of Research and Analytics at Triggerise, who will be sharing how Triggerise is collecting data to the last mile to inform program progress and program design. And our last presentation today is from Zipline, from Laurel Wade, who is the Director of Health Partnerships at Zipline. And she'll be talking about how Zipline is optimizing last mile distribution through monitoring and evaluation of their services. So those are the very exciting presentations that we have for today. And I really just want to encourage us to put our questions, because our timeline is a bit tight to be able to put in all this together within the time that we have. So I kindly request that if you have any questions, kindly indicate on the chat board, indicating to whom the question is directed to, as well as what your question is. And we will be able also, the presenters will be able to respond on the chat as well. So I want to take this opportunity to welcome Rosemary Kindyomunda from UNFPA to give us some background on the Condom Strategic Initiative, what they are doing, and how measurement is shaping up within the initiative. So welcome very much, Rosemary.
Which I sent to you that some officers were picked twice.
Joseph,
Thank you.
What Joseph told me on phone.
Hello.
Yes, yes, Rosemary, kindly go ahead. Thank you.
Thank you, Lucy. Good morning, good afternoon, good evening, colleagues. I don't know whether I'm presenting from my side or you are loading the presentation from there.
The presentation is on. Can you be able to see it?
Okay.
Yeah.
Yeah.
You just need to tell the presenter to click.
Okay. I will be sharing on the Global Fund supported condom initiative, but also some background information on condom programming generally and condom program M&E specifically. So Rosemary Kindyomunda, I work with the UNFPA regional office, Eastern Southern Africa, and also focal point for the condom SI at regional level. Next, please. So what is the Condom Strategic Initiative? It's a global fund supported among the several initiatives that are running. And this one is delivered through a partnership between UNAIDS and UNFPA, and largely informed by the low condom use in this region, well below the global target of 90%, and a realization that this is largely informed by low capacity in condom program stewardship, mainly looking at a priority setting, resource allocation, demand creation, last mile distribution, community engagement, and so on. So our objective is to catalyze improvement in the quality of condom programs, largely focusing on differentiation, equitable and people-centered programming, and looking at outcome results of increased condom use among priority populations, and at impact level reduced number of HIV infections, as well as other SRH benefits, including reduced unintended pregnancies and STIs. And specifically, we look to strengthen national and subnational institutions, ministries of health, national AIDS councils, and systems for improved comprehensive condom programming, and also a focus on innovation, especially in demand creation and the last mile distribution, and a focus on total market approach. Currently, this SI is, as we call it, is in 4 countries: Malawi, Mozambique, Uganda, and Zambia. If you can go to the next slide, please. Here is a quick overview of progress on condom at outcome level as we have it under the global targets. This one specifically picks the GPC countries, and you can see that we are not doing well. Condom use, especially among women, 15 to 49, none of us is in green. And the condom use among men, just a couple of countries in green. I think that's Namibia and Zimbabwe. Several yellows compared to condom use among females, but generally an improving picture for the other outcome indicators on knowledge of condom as a method among both men and women, and the gender specific kind of focus. Women justified to insist on condom use. And just the last column alerts us to understand where these countries are in reducing new infections. The purple color showing those that are not doing very well, and green doing much better. But we also know that we did not achieve the decline in new infections as targeted. Next, please. Next slide. So briefly, this is an overview of the Condom SI investments. 3 pillars: program stewardship, last mile distribution, and demand creation. And within each of these, there is a focus on data and analytics. And I will not dwell so much on this slide, but you can pick and raise some questions during question time. So under stewardship, we look at different aspects: the coordination, the resource mobilization from domestic and the external sources, the total market approach, the oversight, especially for both the public and the commercial sectors. And the last mile distribution, we are looking at our condom needs estimation, data, and the planning rollout up to the user, and also for demand creation. We take note, especially for demand creation, that we've not been doing well on data correction in that area, as we will see ahead. So I will move to the next slide. This one picks on reflections on condom programming, monitoring, and evaluation and data management from what we have so far seen in these 4 countries. We had an extensive situation analysis at the beginning that picked several of the bottlenecks at inception stage. And we've had a follow-up in each of the countries. And we bring these ones here just to share what could be challenges elsewhere and what needs to be addressed. So under each of the pillars, and starting with the stewardship, we all know that condom is a proxy indicator for measuring HIV prevention program coverage among adolescents and young people, among KPs. And we also note that this is usually pitched at outcome level, tracking condom use at last high-risk sex. But several, for these countries, there is acknowledgement of deprioritization of the condom as a cost-effective HIV prevention intervention. And this is seen through what is happening at policy, programming, service delivery, and at community level, the user side of it. But we take note that there is increased donor investment into condom as a commodity, especially the free condom in these 4 countries. But there is limited program tracking for the delivery of the program. So if you compare, for example, with how we track the ARVs, it's not the case with the condom. The condom is brought up to country level, and then we are left to check whether the person used the condom at outcome level. And generally, there is lack of up-to-date data, 2017, 2018, which may not really apply to current situation, lack of condom targets, and in some area, the targets are very unambitious, lack of indicators in national documents, lack of M&E frameworks, just to understand what kind of data we need, what mechanisms we have in place to collect that data, and how we are promoting its use. Lack of knowledge of like hotspots, user profiles, their needs, their willingness to pay, lack of condom TMA targets and market intelligence generally, lack of implementation science, what is working, what is not working, and the functional coordination structures for bringing us together for accountability. Same applies with tracking last mile distribution. There is fragmentation in the condom needs estimation by the different partners who bring in condoms. And there is an expectation that quantification is informed by consumption data, which is usually not available, and the lack of condom commodity tracking mechanisms. Some programs do them in a fragmented manner, paper-based mechanisms that may not be very efficient, and lack of data visibility on profile of users reached. As I mentioned, same case with the condom in demand creation, condom in integration. We are pushing for integrated approaches, but usually the condom as a piece gets lost in the bigger picture. We assume we have integrated, but we don't have approaches for actually tracking the pieces that are in that integrated package, like it is done for the other interventions. There's inadequate capture in our health management information systems. For one, it may be maybe one indicator or two, and even the points from which this data is collected are few compared to the points where the condom may be distributed within the system, and the lack of differentiated condom programming. So whereas we are held accountable to track what has happened with KPs with young people, our systems do not differentiate the kind of data that is picked. And there is less focus on user feedback. For several countries, there is the now community-led monitoring, but the condom is not yet on board on that platform. Next, please. So we have some early learning because there is dedicated action on this platform. On this side, we have our CSI, what we call our smart outputs, specifically on data and analytics. And we focus on revised and improved condom needs estimation tool. We can share more about this globally. It's there's a user manual that is being developed, but also a move to actually institutionalize its application, because currently several countries were just using it on and off, especially around global fund proposal development processes. Then a comprehensive condom program data available, accessible, and effectively used to guide key decisions. Condom distribution dashboard consistently updated, understood, and effectively used. So in some areas, there's data being picked, but it's not visible and it's not easy to use. And one of the pieces we are looking at is how to establish these dashboards. And then finally, integrating condom indicators into DHIS2. So we've had different countries based on their contexts doing different pieces. The application of the program self-evaluation tool, this is slightly different from the program self-assessment tool, the PSAT, but it builds on the PSAT. So we applied the PSAT at the beginning of the program, and we are going back. We are using it as an evaluation tool on this SI. We are also having to focus on developing the M&E frameworks, as I mentioned, and designing and rolling out condom program guidelines and tracking tools, whether as standalone or integrated into other HIV SRH tools. Then advocacy for integration of indicators into management information systems, conducting condom market analysis, and developing TMA guidelines and targets where they are not set. Condom forecasting and quantification, as I mentioned, specifically institutionalizing the CNET and applying it as part of the broader RH-HIV commodity forecasting and quantification processes. Then rationalizing integration into other SRH and HIV programs, engagement in streamlining last mile distribution mechanisms, and engagement in development of demand creation tracking mechanisms. Here we are still young and need to learn from other settings. And we specifically, as a learning program, are focusing on identification and documenting promising practices. So currently, we can say, we can share a lot about CNET institutionalization. We are developing M&E frameworks. We have one country that has a national condom management information system operational. We do have countries that have good practices on condom target setting and data collection through KP-led organizations. We are working out phone-based condom stock tracking mechanisms linked to HMIS and may tell a good story later. Similarly, national last mile distribution that are to GSI mapped hotspots. We have a good practice running where we also are taking other countries to pick, and also working with existing systems to track condom user data. So for some areas, we may not need to establish anything new, but look to optimize what is already available, like the UNICEF U report. Next, please.
You have 1 more minute, Rosemary.
Yes, just flashing global guidance on results frameworks for the condom program. The fact that we need to take it through the whole hierarchy, activities, outputs, outcomes, and impact. And just to emphasize that we've largely focused on outcome and impact, and to a great extent, failed to pick the output piece, which really is the base for the outcome and impact. So across the 3 pillars, please take note of the results framework and the expectations from your country programming processes. Next, please. I have seconds now. So this is a tool where you can pick this detail from, developing effective condom programs, and you can get more detail from this. And also the next one is the CNET tool. I would add a sentence or two. Next slide, please. To say that once you work properly with this CNET tool, then you will be able to establish all your data needs around comprehensive condom programming, people-centered condom programming, and you will be able to establish where you have gaps and discuss together with partners as to how you can address those gaps, and then use this tool to support in target setting, in resource mobilization, and what have you. I think, yes, thank you very much. Please stay safe, play safe, condomize.
Thank you so much, Rosemary, for that very insightful presentation. I think it's clear that a lot of activities go on for condom use, but not enough being done on measuring the outputs that inform outcomes and impact. Thank you very much. Continue to share your questions on the chat, and we'll move into the next presenter. The next presenter is Boniface Epoku from Uganda, measuring the right indicators for a successful condom program. Welcome, Boniface.
Thank you very much, Lucy, and thank you, Rosemary, for the insightful presentation. Good afternoon, good evening, everyone. My name is Boniface Epoku. I'm the program officer responsible for condom programming at the Ministry of Health here in Uganda. So I'm going to take us through measuring the right indicators for the condom program. So basically, just to give us an overview of the picture of Uganda, of how Uganda looks like, we realize in regards to contraceptive use, we realize modern contraception used by women is around 27%. But when you relate it to condom programming, condom use, we realize we are still at 3%. So that tells us there's still more work to do. And then when we look at condom use among sex workers, that stands at 69%. This is almost double condom use in the general population by women, which is at 36%. Then we also realize among men having sex with men, we realize condom use is considerably lower, which is at 39% compared to the general population. Men in the general population, which stands at 62%. And equally among PL-HIV, we still realize condom use is just at 35%. Other most at-risk populations, we have the truckers, which stand at 55%, fisher folks at 54%, plantation workers is at 55%. Can move on. Next slide. So basically, Uganda is guided, condom programming in Uganda is guided by the National Comprehensive Condom Programming strategy and implementation plan, which focuses basically to increase access to male condoms, which of course ultimately results to reduction in STIs, including HIV and unintended pregnancies. And this basically focuses on ensuring that there is adequate information, access, and correct use to quality condoms. Next slide. So basically the strategy is guided by 4 objectives. The first one, we're basically looking at program management, condom program management, which we want to be strengthened in at least 50% of the districts in the country. And then we also want to increase condom use in the less high-risk sex. Currently for women, it stands at 38%. And then for men, it stands at 62%. But our target, at least by 2024, we want to have these figures go up to around 75%. And then access to condoms through the commercial sector. At the moment, we are at 35%, at 14%. So our target is to increase that to around 35%. And then we also want to ensure there is domestic funding for the condom, which we target to increase to at least 30%. As you realize in the course of the presentation that most of the funding to condom programming is donor funded. So just to take us through that, just continue, next slide. I just wanted us to answer a few questions here. Just I wanted us to know, just to tell us where do you just respond to that and then you submit your feedback. Why are condom indicators important to us? Just go through that brief assessment that you have on your screen there. And then the other is, can you be able to tell us or name any condom indicators that you're currently applying in your country? We have around 1 minute or so to have this done. I hope we're about to be done with this assignment. Okay. So thank you very much. Thank you for the feedback. So as you can see, we have got quite some good feedback. One, indicators align condom players around a common goal. Indicators tell us about changes in condom use and condom availability, which is coming to around 78% of us. And then indicators help with accelerate budgeting. So we have also gotten feedback on a number of indicators that have been provided. So we can move on. So thank you very much. Some of the indicators, as we have already stated, they help us, put us in a common goal in regards to our condom programming. And then, as we have also noted, it helps us in setting pace for the direction in terms of budgeting. And then we all know that condoms still remain as an expensive and a cost-effective method for HIV prevention and unintended pregnancy, together with the other STIs. So condoms still remain key. And when we have indicators, they really guide us in regards to budgeting and then setting pace in regards to programming as well. So we also realize that it's always very important to make sure that our condom indicators are smart. They should be specific, measurable, and should be within time bound, because we should always be able to make sure that we have targets that are measurable. We can move on to the next slide. So based on the objectives that were shared earlier, so we're deriving our outcomes from those objectives. We said we wanted to ensure that 50% of the districts have the capacity to manage the condom program. So as a country, our vision is basically to establish a functional capacity for condom program in 50% of the districts. And in order to achieve that, we are being guided by a set of indicators. The first indicator is the proportion of districts with the capacity to manage the condom program. So how have we been able to measure that? One, so far, we have been able to appoint a condom programming focal person per district. Then we also have a condom coordination committee with a budget.
So you can just try and just recap from each slide, because you have 3 more minutes.
Okay, so basically the means of measurement are clearly stated there. And then how have we been able to report on that? We have a Uganda Demographic Health Survey, which is a nationwide survey that helps us to catch information regarding to the indicator. So far, we have had a few achievements in regards to that indicator. We have, as I stated earlier, condom focal person appointed. We have operational guidelines in place. We have been able to strengthen the functionality of the National Condom Coordination Committee at the national level. And then we have also developed the distribution guidelines. Next slide. In terms of objective 2, that is increased condom use at last high-risk sex. So our indicator, which is guiding us, is basically percentage of adults aged 15-49 who use a condom at the last high-risk sex with a non-regular partner. So the means of verification is basically there. We're looking at condom use in the last high-risk sex increased by 75%. Then as well, the comprehensive knowledge on HIV prevention. Then we're also looking at reduction in the number of multiple sexual partners by that proportion. Still, the reporting you get from Uganda population-based HIV impact assessment, and then the Uganda Demographic Health Survey. In terms of current achievements, we currently have a national survey, which is conducted by one of the partners with funding from Global Fund, that will be able to tell us the picture where we're standing. Next. Still on the same objective, indicator 2 is the percentage of males and females aged 15-49 engaged in high-risk sex, reporting condom use in the last risk sex. So the means of verification is right there. We are looking at 75% of both male and female reporting condom use, 75% of the population having comprehensive knowledge of HIV, and then we are looking at reduction still in the number of multiple sexual partners. Still, as the previous, we are still going to have that survey, which will be able to give us the findings in regards to that indicator. Next slide. So indicator number 3, still on outcome area 2, is a percentage of most at-risk populations 15 reporting consistent condom use. So basically, still we are looking at the survey to be able to give us results on how far we have gone, because we intend to increase to at least 75%. So that survey will be able to give us the outcome. Next slide. So we were looking at indicator number 4 under that result area is percentage of women aged 15 to 49 who know that HIV is prevented by using a condom. So still we are looking at comprehensive knowledge of HIV prevention and then reduction in the number of multiple sexual partners. Next slide. Our outcome area number 3 is basically we want to increase availability and access to commercial condoms. As we had stated earlier, currently we are at 14%. So our target is to have it increase to around 33%. So we are guided by 3 indicators. One, we are looking at the proportion of condoms distributed through the commercial sector. Then we are looking at the proportion of total male condoms procured against the universal need. And then we're also looking at the proportion of condoms distributed against those which have been procured. Then how are we going to measure that? We are looking at the volumes of condoms distributed through the public and private sector, as well as the commercial sector. Then we are also looking at retail audits to be able to give us how we stand, the picture of how the market looks like in terms of condom programming. And then we're also establishing the private sector engagement task force, which is guided by the TMA, a plan that has already been developed by the country. So in this area, we have so far achieved, we have been able to develop a total market approach. And then we also have guidelines which are going to guide us towards implementation of the TMA. Next slide. Looking at the domestic funding, our focus in this area is to ensure that we increase domestic funding to at least 30%. But as per the previous presenter, we realize it's still an area that we're having a challenge. Most of the funding that we are getting as a country is from the partners that you can see over there. We still have limited resources that are being allocated to condoms locally. Next slide. So our next outcome area is to increase demand for condom use at community level. So we are looking, it's also guided by 3 indicators. That's a percentage target of population who feel confident negotiating for condom use with a partner. Then we're also looking at a percentage target of population who perceive themselves to be at risk of HIV, and then the percentage of the target population who have comprehensive knowledge on HIV prevention, that is at community level. So basically, how will we be able to get that achieved? So we are looking at information and communication on safer sex and condom use, community level and social media condom campaigns. Then we're also looking at strengthening the BCC, behavior change communication. And then we're also looking at demand creation initiative through peer-to-peer approach. So that is basically what we intend to do to be able to achieve that outcome area. Next slide.
Boniface.
So what have we been able to achieve based on the need through these different interventions? By 2021, 2020 targets, our estimate was 282 million condoms, but we're able to distribute 192 million condoms. Equally, through the TMA that is in the commercial sector, we're able to at least distribute 17.2%, which is slightly about 3% from the original target of 14%. And then when you look at the total market, we realize that around 73.8% of the condoms are what we get from the public, that is the public condom, which is donor supported mainly. Next slide. So thank you very much. So that is basically an overview of the condom program in Uganda.
Thank you very much, Boniface, for your very thoughtful presentation. It's very clear the outcomes that you're measuring and how you're verifying that information. Next up, we have Ghana. We have Ghana, that's the next presentation, Dr. Koduah, using data to design, manage, and monitor quality condom programs. Welcome so much. Welcome, Dr. Kwadwo. We can't hear you.
Hello?
Yes, now we can hear you.
Great. So my name is Koduah, also head of clinical care at the National AIDS Control Program in Ghana. Greetings to everybody and many thanks for having us. What we're going to try to do within the next 10 to 15 minutes is to try to give us a picture of how Ghana is trying to use data to help us manage and monitor the condom programming that we do. Next slide, please. Yeah, so like probably a number of countries, we have the National Condom and Lubricant Strategy. That is the overarching policy that guides what we do in that space. Now, as expected, the overall goal is to improve access and indeed the use of condoms that are quality assured, as well as lubricants. Now, specifically, we hope, or the document seeks to help us improve and maintain an environment that is conducive for condom and lubricant programming, and also increase demand for the commodities, as well as ensuring timely and continuous availability of the commodities to support the programming. And then finally, to ensure that sustainable funding, and the key word here is sustainable. Sustainable funding is available for our condom programming here in Ghana. Next slide, please. Now, data is key in public health programming in general, in public health supply chain management, very, very crucial. And with condoms, obviously, it's even more because of the nature of how condom programming is. You have so many actors, at least in our country, in the public health system, in the private health system, CSOs, and so on. And so data is very crucial, or as good a data that you have is very critical. And among other things, it's very important for forecasting and supply planning or quantification, and also to inform distribution, because efficiency, especially in our part of the world, is important due to obvious reasons. And so distribution has to be informed by very reliable data in terms of where it's most required and so on. And also with data, we are able to implement and undertake activities when required. And of course, finally, advocacy. Advocacy on many fronts, with government, of course, with partners and so on. Clearly, the language that many understand is when the evidence is clearly laid down before us. And as far as the quantification team is concerned, it includes all the key players. And so we have our procurement persons in there from the ministry. The Ghana AIDS Commission in charge of HIV policy, the AIDS Control Program responsible for the technical response, various organizations, the public sector, CSOs, partners, and so on. Next slide. And as we go on, I need to mention that it's important the team is very, very comprehensive, because you don't want to have any sector missing out. Once you have that, it would affect the forecasting and supply planning. And once you start to execute, you have problems. So we try as much as possible to ensure that all the key sector players are part of the quantification team. Now, the quantification is annual. However, every 6 months, we take a step back and then review the performance of what was forecasted over the past 6 months. That notwithstanding, every month the pipeline is monitored, is updated, and necessary action is taken where necessary. Now, even before the quantification, there is a pre-quantification exercise which includes various stakeholders. And like I mentioned, not only the public sector, the private sector, social marketers, and all that. And it's an opportunity to help us come together, look at how various implementers and various stakeholders performed over the past year or implementation period, and help us to project going forward. Among other things, also understanding plans of key sector players, so that it would inform the projections. Next slide. Now, the priorities for Ghana when it comes to condom programming includes, HIV prevention and control, same for sexually transmitted infections, and of course, as mentioned by some of the other presenters, to prevent unintended pregnancies. And so with that, it's expected that our focus mainly has been the 15 to 49-year-olds. Aside that, and within these groups, we also have various implementation strategies. So aside the sexually active people, we have dedicated implementation strategies for persons living with HIV. So condoms are distributed for free. I think there is some, yes, are distributed for free to persons living with HIV at various HIV clinics across the country. We also have dedicated strategies and programs for sex workers, men who have sex with men for obvious reasons, because in our country, like many others, the prevalence among these populations for HIV and other STIs is disproportionately high. Next slide. And so in terms of the forecasting, the data that we use mainly, of course, is distribution data. As you may know, obtaining consumption data for condoms is not very straightforward. So we try to triangulate as much data as possible. The consumption data available, rely on the distribution data from the process points to consumption, and then try to collaborate with all the key stakeholders to utilize other resources available, including surveys, including commodity costs available, and try to use all the data to help us to be able to forecast as much as possible based on something that is informed and not arbitrary. Next slide. Yeah, so still on that, as I mentioned, consumption data is always not easy, so we rely as much as possible on where consumption is not available, proxy or as close as possible. Distribution data is there. Commodities available in the supply chain, because you need to know as you forecast what is already available in the pipeline, orders made, what is coming in, what is already available at various levels of the supply chain, and also to help us to project based on what the various key actors are saying. And so with the unit cost and with the plans, we are able to project and then forecast as effectively as possible. Next slide, please. Yes, so as I have described, and you can see from the charts that we try to look at various target populations. Of course, the general population is there. We have various subpopulations I did mention, and also we consider the various data and all that. And then we use that to have the forecast. And once we do that, we provide for, free male condoms, commodity costs and so on. Or we provide condoms for free, as in the male condoms and female condoms as well. Now, having done all this, the outcome is very key for us in Ghana. Of course, clearly, once we hear quantification, the first thing that comes to mind will be the procurement, yes. But beyond that, advocacy is very key. It's helped us on so many occasions to have resources from various partners, from government, based on the numbers, what it was telling us in terms of the historic cost and what was happening in terms of consumption and commodities in the pipeline. It also helps us to even design the program, because if you analyze, and as happened recently in the country, if there are challenges or there are efficiencies in one sector, obviously following analysis, you try to maximize and then improve upon the efficiencies. And that's in some cases would even include capacity building. Next slide, please. Yeah, so in terms of the distribution, we, just like for the quantification, we rely on what we call the GILMIS, or the Ghana Integrated Logistics Management System. It's an online-based supply chain LMIS, and the ultimate vision as we continue to roll it out is that anytime health commodities are consumed, including condoms, we will be able to have the consumption reported. Now, where available, we use this to inform the distribution. We also use data from trends and other surveys. We also look at the lifestyle, what is happening, programmatic interventions that are taking place, and other relevant or related sources to inform the distribution, to minimize wastage and also stock outs or stock tension. Next slide, please. Yeah, so as I intimated earlier, so in condoms are provided for free, not only in the public health facilities, but private health facilities as well. In Ghana, depending on the services provided and the classification, what is provided to public health facilities or government-owned facilities, the same courtesies are extended to the private sector. So in the same way, it's provided for free through the private health sector as well, because some of them are even HIV treatment sites and also provide family planning and other related services. So through these organizations, we are able to reach the formal, informal sectors and also provide some of these resources for community outreach. And of course, we have the social marketers who also provided mainly through the private pharmacies and some community government hospital pharmacies as well, but mainly the community pharmacies and other community outlets. Next slide. Yes, so this is how the condom distribution or management system in the country looks like. So once the condoms come in, there are two main outlets. So the social marketers is one conduit, so through them to the community pharmacies and other community outlets. And then through the government system, going through the central medical stores. Now from that point, it goes to the public health facilities, private health facilities as well, also to the CSOs and other non-governmental organizations that implement various strategies. Now, so for instance, when it goes to the regional medical stores and the public health facilities, some organizations can access it for various interventions in the community, as well as some of the CSOs, including Global Fund PRs, that also access directly for use in their areas. We also have the private sector, and the private sector, we collaborate with them, some organizations, some companies, and so on, for various interventions to promote condom programming in the country, including workplace interventions and support. Next slide. So, data helps Ghana it helps Ghana by providing evidence, as I indicated, for stakeholders, so governments, for partners, to procure the commodities required. With limited funding available in our resource-constrained settings, every decision taken by governments obviously would have to be prioritized. And so if you have data, the data obviously helps, and same with the partners as well. So in the past, when government has supported, or when government continues to support, the interventions are always based on what the data is telling us. Now, it also provides us with evidence to make interventions in specific areas in a timely manner. And there have been times, even earlier this year, where based on what the data was saying, we had to suspend distribution or limit the distribution of condoms to certain sectors in favor of expanding various strategies and interventions in other areas. And it's all as a result of the data that was available. The next slide. So thank you very much. What we've tried to do is to briefly give us an idea or share with colleagues what Ghana has been doing in terms of using data for condom programming. So among other things, for the quantification, for the development of programmatic strategies, developing interventions, and so on, to help us improve what we do. And that largely accounts for a lot of the successes that we've been showing over the years. Thank you very much for having us.
Thank you so much, Ghana, for the very comprehensive presentation. And it's really encouraging to see how you're using distribution data at the output level, just using distribution data to inform program design. Thank you so much. Any questions, kindly direct them on the chat. I want to request the presenters who have made their presentations to look through the chat so that you can be able to respond to any questions that are there. The next presentation is an interesting presentation from Triggerise, who do sexual and reproductive health service delivery at community level, targeting adolescent girls and young women. And it's going to be very interesting to see how they're using and collecting data and using it to design the program. Welcome so much, Dr. Hildah.
Thank you very much, Lucy, and happy to be engaging in this webinar today. So I work at Triggerise. I am the person in charge of monitoring, evaluation, research, and learning across the work we do at Triggerise. And so today I will just take you through how we at Triggerise use real-time data to inform our programming, to track performance, and just really for adaptive implementation. Next slide. And so before I do that, I think I'd like to just take us through a bit about who we are as Triggerise. We are a global not-for-profit organization young people to make positive choices using proactive technology, real-time data, and behavioral insights. So we work, of course, we just don't work with adolescent girls and young women. We also work with young men as well. So our target audience, our target is adolescents and young adults, aged 15 to 24 years. And so through our digital platform and our local ecosystem of partners, we're able to connect our beneficiaries, these adolescents and young adults, to existing local service providers to meet their health and wellness needs. Next slide. So we have been in operation since 2014. And we have more than 150 staff at our organization. We have operations in a number of countries, including Kenya, Uganda, South Africa, Burkina Faso, and Cameroon. And so in terms of our reach and what we've been able to achieve, since we started our work in 2014, we've been able to reach more than 2 million young people across these countries and connected them to about 1.2 million sexual and reproductive health, health products and services. We've got a number of partners that we work with, including the Dutch Ministry of Foreign Affairs, Children's Investment Fund Foundation, the Aga Khan Foundation, Grand Challenges Canada, Elton John AIDS Foundation, the Dutch National Postcode Lottery, UK Aid, KfW Development Bank, amongst other partners. And so we've seen an upward growth in our portfolio, such that by last year, 2021, we had grown to $11 million in terms of our revenue. Next. And so we mainly work through four main approaches. Number one, we support. We do not compete with our local partners, but our implementation approach allows us to partner with and direct funding towards local organizations across different health areas, our sexual reproductive health. And so we invest in these partners so that to ensure supply, demand, and quality assurance so that we are able to deliver results. And so we connect young people to free and subsidized services. So our technology platform and our ecosystem connects young people to a range of health and well-being services. And we do this at various service points, including clinics, community health organizations, and pharmacies. The critical thing about our work, in addition to supporting them to access the services, is that we encourage them to get user feedback, to provide feedback once they have accessed these services. And this really helps us to ensure quality of service provision. We motivate behavior through nudges. So our platform leverages behavioral science approaches using nudges, subsidies, and reminders that ensure sustained positive health-seeking behavior on both the provider and user side. And then we obviously we don't target young people through siloed approaches. We don't do vertical intervention. Rather, our platform integrates with partners, providing relevant services across the various service portfolios or sectors. And this really allows us to achieve service user. Next. Next slide. So what is the user journey of the young people that we engage through our platform? So the first thing that happens is that a young person is able to sign up to our Tiko platform. So this is our technology platform. It's called Tiko. So they can do this through either enrolling through a community mobilizer or through a friend. And they could do this in one of three ways. Number one, smartphone, they could enroll through a WhatsApp or Telegram, or with a feature phone, they can enroll through SMS. And in case they don't have access to a phone, they can enroll through a digital membership card. And so once they enroll, the platform really provides them with an option of a network of pre-qualified clinics and pharmacies that they can choose to visit depending on the need or the service they're interested in. And so, once they enroll in this platform and they have access to this platform, they can access contraceptive services, whether short-acting or long-acting reversible contraceptives, whether HIV testing services, whether they'd like to access PrEP services, ART, or other well-being services like mental health screening and support. But also young people are able to access various other services, including counseling, as well as skills development support with employment. And so in terms of the services, they're quite affordable. A lot of them are either free or subsidized. And once the young person accesses these services, we encourage them to rate the quality of the service. And this ensures provider quality and accountability. So once they rate the services, we make sure we reward them. So there's a reward point mechanism such that with each rating, the Tiko users through the platform receive rewards that they can exchange through participating local retailers for such things as sanitary towels or stationery. And then, through the series of nudges from Tiko prompts users to attend appointments and follow-ups. For example, when they are nearing, a girl or a young woman is nearing a time to go for a refill of oral contraceptive pills or their PrEP refill, our platform is able to send a reminder. And this really ensures behavior change and a cycle of healthy decision-making. Next. And so we had a video that I wanted to play just so that you see how young people can enroll on our platform. Can you play that? Is it possible to play?
Hilda, just in cognizance of the time, you can be able to just summarize through.
Okay, no problem. It was just a recap of what I've shared. So we can go to the next slide. Next slide.
Next slide, please.
Is it moving? I can't see it on my side. Moving?
Yeah, it's not moving yet. Shafala, are you able to move us to the next slide? Okay, there you go.
Okay, yeah. So what happens is that because the Tiko platform really enrolls young people and provides them an opportunity access services through participating pharmacies and health and private facilities, what else the Tiko platform does for us is, I think we can skip the video and just go to the next slide where we were. Yeah, so the Tiko platform is able to collect real-time data. So as soon as a young person enrolls on the platform, that data gets sent to the platform, or as soon as they access a service, that data again gets sent to our platform. And you can see like every single day, the data gets updated on our website and on our Tiko platform. Next. So this is just an example, this on the previous slide, of sort of like some of the screen grabs that I was able to take from our dashboard that show like the regular real-time update of the services that are being delivered. So you can see, for example, we are able to see uptake, and also we are able to track the impact or what the program has been able to achieve around improving the sexual reproductive health lives of young people. Next. And so the other thing is that, because the data comes in real time, what my team and I do as the research monitoring and evaluation team is that we are then able to create visuals with this data so that as soon as it updates on a day-to-day basis, we're able to see the changes in uptake of the services. So we can intervene on areas that are not doing so well. Next. And we use Tableau to visualize our data. So as soon as we are able to design dashboards for whatever program we are working on, we provide access of these dashboards to program our program teams and as well to the donors. And so they're able to access the data on service uptake as it happens in real time. And where the rating is done, they're also able to access that information. So just the real-time data collection that we get enables us to do agile programming because we are then able to promptly troubleshoot any issues that may be affecting service uptake. Next. So this is just an example of how we use our dashboard and visualize the data and track that. So for instance, we are able to show program our dashboards to show targets of each indicator against performance. So every day as the numbers stream in, we are able to see what is happening and changes. And so you can see that we have on this chart, we have some in amber color and some in red color. So you can tell that, the red, we are not doing so well. So it helps us to know, given the time lapse, how can we track or fast track performance of our program? And we choose different visuals depending on the indicator that we are showcasing or that we want to visualize. So you can see like the different visuals, whether it's trend data or whether it's age categorization or whether it's services. So we can use different visuals to present that data. Next.
3 more minutes, Hilda.
Yeah, okay. So just as part of one of the programs we run on HIV, you can see that we are able to track, for example, total HIV testing services given, and we can categorize those in the different service delivery points, as well as how many young people have been able to access those services. Next. So the other critical thing, because we work at really ensuring integrated services, dashboard that you see within this time period, January to October this year, you can see the number of young people that have accessed both long-acting reversible contraceptives, in this case implant, as well as mental health. And you're also able to see those who are taking mental health services on top of a short-acting method of contraception. And we are able to do that across all our SRH services, including HIV services, as well as others. So we are able to show what integrated services are being taken by young people. Next. We are also able to see, dashboards to help track sustained use of service. We're able to tell how many have come back for repeat services. We can tell who has come back for a refill of their oral contraceptive method, or a refill of their PrEP medication, or a refill of their ART treatment as well. So we can tell that through our dashboards, and we're able to do that on a regular basis. Next. The other critical part that, in terms of, improving quality of services, because young people are able to rate the services as they exit service delivery points, we are able to show that data. So Tiko platform allows us to rate the service, allows users to rate the services they've received. And so you can see within this period, a lot of young people to the services they've received, demonstrating high satisfaction. So this really helps us, and the program team really, to troubleshoot areas of weakness, especially where we see ratings going really down. And we do ratings, we have a series of questions that we ask on the platform that help us to track this. Next. Next slide. Okay, yeah, so outside of the Tiko platform data, we are able to collect other data off of that platform that help us to inform our programming, track, provide additional data to track our programming, or delve deep into areas that we feel may be having an issue. So we do, for example, routine quarterly client exit interviews that complement the rating data. And so we are able to showcase that as well on our dashboards and see, for example, the areas that really are of concern, that need a bit of trouble, a bit of attention. So beside the Tiko data, we are able to collect qualitative data, quantitative data off of the platform, and different types of data. Next. Thank you.
Thank you so much, Dr. Hildah, demonstrating how Triggerise is using technology to collect and use data. The next presentation is from Zipline, Laurel, that also uses technology. So welcome, Laurel, and tell us more about what Zipline is doing in terms of integrating services at the last mile.
Great. Thanks so much, Lucy. As Lucy said, my name is Laurel Wade. I'm the Director of Health Partnerships at Zipline. It's been really great to hear and learn from the other panelists and presenters today. So I'm going to walk through how Zipline's using data and routine performance monitoring to optimize integrated last mile distribution. Next slide. So if you haven't heard of Zipline, Zipline's a mission-driven logistics company focused on transforming health access through transformation of global health supply chains. So we started working in Rwanda in 2006, focused on delivering emergency blood to just a handful of health facilities. And over the last 6 years have expanded dramatically. Today, we have national scale in Rwanda. We're currently delivering over 250 different health commodities and over 75% of the blood supply outside of Kigali. We've expanded beyond emergency deliveries, and we now support routine deliveries, stock out response, and continue to do emergency deliveries. But today that makes up around 10% of our deliveries. So we're a government-led solution. The way that Zipline works is we integrate directly into national supply chains. So we work hand in hand with governments to transform and optimize national supply chains. We don't limit our operations to specific disease areas, but instead we work really closely with governments, partners, and funders to identify, test, and scale the most impactful use cases. So today we've expanded beyond Rwanda, and we have national level operations in Rwanda and Ghana. We're operating in one state in northern Nigeria and Koduah state, and we'll be operating in Kenya, Koduah, and 2 additional states in Nigeria by the end of the year. Next slide. So I'm going to walk through our approach to monitoring and evaluation at the last mile. But before I do that, wanted to play a short time lapse just to orient everyone to Zipline's solution and how it works. So if you can, start the quick video, I can walk through it. So Zipline's often known as a drone company, but we think of drones really as a tool to achieve our broader objectives around offering centralized warehousing and on-demand delivery through our full end-to-end supply chain solution. So Zipline's solution is a 3-part system, which includes warehousing, distribution, and data performance and management. The way the system works is that Zipline puts up distribution centers, which houses our fulfillment and flight operations. So on the left side of the time lapse, you're looking at what we call a highway in the sky. So the green circle in the very center is one of our distribution centers. All of the lines coming out are pre-mapped routes where drones are going out, dropping packages to health facilities and other community distribution points. Those are the pink dots that you can see. And then coming back and returning back to the distribution center. What you're looking at on the left side is a 23,000 square kilometer catchment area. So as Zipline scales across the country, we put up additional distribution centers to achieve national scale. And then on the right side, you can see Zipline's operations really in action. So warehousing or fulfillment operations on the top right is where Zipline receives commodities from national or regional medical and cold stores. So every item that comes into our system receives a unique ID code, and it's tracked and traced in real time to the point of delivery. And then flight operations are on the bottom right, where you can see an aircraft taking off and being recovered in the back as it returns to the distribution center. Our aircrafts or drones are really built for reliability and range, which is critical for last mile distribution. So each aircraft can fly around 100 kilometers with a maximum round trip of 200 kilometers. And you can see we're about halfway through the day now, getting into the afternoon, and have multiple drones in the air, have delivered multiple packages and over 750 products, to give you a glimpse into the scale of Zipline's operations. Next slide. Great. So as I mentioned on the previous slide, when I walked through our three-part solution or system, data and performance management is a third one and is a critical component to all of our operations. It really cuts across everything. So Zipline's track and trace system, which is what we call our data and performance management system, enables real-time visibility into the journey of a commodity from the point that it enters our warehouse or fulfillment operations to last mile distribution. The system was initially built with an eye towards supply chain optimization, but we're now starting to explore additional applications to better support health facilities with demand planning and forecasting, optimizing programs by using supply chain data to better understand patient level demand and patients' preferences for accessing commodities. So the way it works is that when commodities come in through receiving, which was fulfillment operations or warehousing, which you saw on the time lapse, every commodity is assigned a unique identifier and entered into our real-time tracking system. So after Zipline receives an order from a health facility or other partner, the order is filled and prepared for delivery. So the commodity itself is linked to the order, which is then linked to the package, which were the red boxes that you could see, which are what are dropped out of the drones, and then linked to the specific aircraft it'll travel in. So after an item's delivered, the package, whoever receives the package, so a health worker or a community health worker, confirms receipt via SMS or WhatsApp. They can also do it by phone, whatever method they prefer. And the whole process is captured automatically and shared with partners and customers to provide real-time and accurate visibility into the process. So beyond tracking an individual commodity and providing visibility into that process, data can also be aggregated and used to assess ordering behavior at the last mile, to better understand demand. And where Zipline is the sole provider of all or specific commodities, the data can be used to support health facilities in demand forecasting and to provide valuable insights into how and where clients are accessing commodities. We also work with governments and other partners to triangulate supply chain, health facility level, and patient level data to study how supply chain transformation impacts health outcomes and patient client behaviors. So to date, the majority of this work has been through Zipline's internal impact evaluations and externally commissioned impact evaluations. But now we're starting to look at how we can integrate it into routine performance monitoring. Next slide. So I'm going to walk through, I know we're short on time too, so I'll walk through a few quick examples of planned or active programs that Zipline is involved in where we're utilizing track and trace really for optimization of programs and distribution of commodities at the last mile. So in Kenya, Zipline, in partnership with AMPATH and the Elton John AIDS Foundation, is going to start piloting 100% community-based service delivery model for HIV and sexual reproductive health services for adolescents and young people. So through this model, we'll be distributing HIV self-test kits, PrEP, condoms, ARVs, and other family planning commodities directly into the community. We'll initially reach clients through outreaches, but then they'll be enrolled into automated refills through Zipline system, where they'll be able to pick up refills at a community distribution point of their choosing. And we'll be assessing the overall goal of the program, which will be focused on increases in continuity of treatment and PrEP adherence, really by bringing health services and commodities closer into the communities that Zipline and our partners are serving. So this program will use track and trace to provide insights into product demand and to better understand where, how, and when adolescents and young people want to access HIV and sexual reproductive health commodities. This will not only allow for us to make rapid course corrections throughout the program, but also inform future policy guidelines around adolescents and young people programming. Next slide. So I'll share one more example, which is quite different. The second example is focused in northern Nigeria in Kaduna State, where we recently began operating. As you probably know, there's significant challenges with insecurity in this area, which has created further access issues for vaccines and other health commodities. And there's large numbers of zero-dose communities in this area as well. So this program is still being finalized, but we're planning to work with Kaduna State and other implementing partners and funders to test and validate a new model to reach zero-dose communities in Kaduna with routine childhood immunizations. So through the partnership, Zipline will provide centralized warehousing and on-demand delivery of routine childhood vaccines to zero-dose clusters in Kaduna State. We'll use the data in collaboration with the Kaduna State EPI team that's pulled through our track and trace system to better understand demand, supply availability, and estimate vaccine coverage. So to better understand demand, data from track and trace, including types of vaccines, number of doses, and ordering frequency will be analyzed. And this will allow for real-time insights and enable the team to study how demand evolves as access increases through introduction of Zipline solution. And then to assess vaccine coverage, given that our distribution center for vaccines is on demand, so we're only sending the number of doses that will be used that day or within a few hours, we'll use demand or orders as a proxy indicator for vaccine uptake at the last mile. So we'll measure changes in immunization coverage to monitor whether children in Zipline served areas are accessing vaccines at an increasing rate compared to control areas. And then on an annual basis, we'll triangulate or overlay this information with official immunization records provided by Kaduna State. Next slide. I know we're short on up and end here just to say that Zipline's really at the tip of the iceberg in unlocking how track and trace can be used alone, but also in conjunction with data from our government partners to accelerate equitable access to health commodities across all of the communities that we serve. So this is a priority for us in the next year, and we'll be working to build out new data products and expand our performance monitoring system. So I'll stop there, Lucy, so you can jump back in.
Thank you. Thank you so much, Laurel. Very insightful presentation. And I know there may be people who have questions, so kindly put them on the chat. I want to welcome Kerry, our Executive Director, to give us some closing remarks. Welcome, Kerry.
Wonderful. Thank you, Lucy. And to the presenters and to the participants, thank you so much for joining us today on this Condom webinar. I just really do want to express my appreciation to all of you for coming, for asking questions, for engaging, for answering the poll, and for really sharing some of the great practices and some of the challenges that each of you are experiencing in your countries. As we've heard today, a strong strategic information program is really critical for designing, monitoring, managing, and evaluating condom programs. And I think there's three things that I've learned today from the teams who have presented. The first is that data collection really must be coordinated across sectors and across implementers and across subnational units and different facilities and service approaches. The second learning that I have from today is that data must provide feedback on the impact of how programs are impacting on condom use and factors that are influencing condom use. And I think the third learning I have today is that feedback loops really need to be nurtured to close the gap between what the innovations are showing, what the programs are looking like, but what the program design and policies are guiding. And I think we've seen today that there are some promising practices, but we also know that there's some key challenges. We also know that there are many structural barriers, preventing us from getting to where we need to go. But I think as the South-South Learning Network, what I would like to just close with by saying is that we have heard a lot today. We still have a lot of questions. And I think really what we would like to do is to try and support the documentation of what's working well, to support its dissemination so that colleagues know what is available, but then really to facilitate relationship building and joint problem solving across the various stakeholders and across our countries. Because what I've learned today is that there's amazing social capital that lies amongst these groups of people, not with consultants, not with kind of development partners, etc., but really in the countries in Africa where these programs are being implemented. And so I really do want to offer our support to helping to link you up, to continue these conversations, to learn from one another. And as I say, to kind of improve the way that countries are able to adapt and implement programs. So I think with that, I would just like to thank you once more, and I would like to ask you, please, if you wouldn't mind spending just a few minutes completing a short poll. We use this as an opportunity to refine and better respond to the ways in which you would like to learn, and so we would really greatly appreciate if someone could please launch that kindly. Otherwise, Lucy, thank you very much for chairing our session and for leading this stream of technical work under the South-South Learning Network. Thank you, colleagues. Once you've completed the poll, you are welcome to leave. And thank you once more.